I'm here today with Dr. Sean Drummond. He's an associate professor here at the University of California, San Diego, and he's a clinical psychologist here in the VA San Diego healthcare system. We'll be talking today about cognitive behavioral therapy for insomnia.
Well, so this is basically where treatment starts. And so after a thorough assessment of patient's sleep history and medical history, psychosocial history, their current sleep problems, then the CBT-I therapist will work with the client to individualize the four-factor model. So what is this particular person's predisposing factors, precipitating events, perpetuating factors? Is there evidence for I'm in bed, I'm awake style conditioned arousal? And we believe that it's very important for the client to really understand the four-factor model and how it applies to them, and for the client to really understand the rationale behind the two main treatments, sleep restriction therapy and stimulus control therapy, before we can really proceed with treatment. And there are a number of other treatments that can get added on to CBT-I, but sleep restriction and stimulus control are the two main treatments that all CBT-I therapists do. And so those are the two that we're going to focus on today.
Great. What can you tell us about CBT-I?
Well, first let me actually explain the sleep diary, because it is critical to the implementation of treatment. In fact, we can't do the treatment without the sleep diary. The sleep diary is basically a data collection tool that is completed every day by the client, starting from the first time you meet them. And the purpose of the sleep diary is to try to gather information about the client's sleep-wake habits, their sleep-related behaviors, and the consistency of their sleep schedule.
So if we take a look here at your initial sleep diary, we can see the average across this row right here is actually about 6 hours. Precisely, it's going to be 6 hours and 6 minutes. So that's about the total amount of sleep you're getting every single night, on average.
Okay.
And data from this tool is also used to calculate the amount of sleep a person is actually getting at night, and the amount of time that they're spending in bed in order to obtain that much sleep. And these two numbers, the amount of sleep somebody's getting and the amount of time it takes them to be in bed to get that sleep, are used to determine something that we call the sleep efficiency. And a sleep efficiency below 85%, which means that the person is actually asleep less than 85% of the time that they're in bed, suggests clinically significant sleep problems.
Okay, I think I got it. So the sleep diary is critical because it gives you the data that you need to do the treatment. Tell us about that first strategy called sleep restriction therapy. That sounds a bit daunting. What exactly is it?
Well, sleep restriction therapy is sometimes called sleep efficiency therapy. And really it's designed to reduce the behaviors or eliminate the behaviors that perpetuate sleep problems, those perpetuating factors that we talked about in the four-factor model that ultimately create conditioned arousal. Okay, stated most simply, sleep restriction therapy is a four-step process. First, the sleep diary is used to calculate the average amount of time a client is actually sleeping, or what we call the average total sleep time. And this is understood to be approximately the amount of sleep that the person is currently able to generate. Second, the client is asked to select a wake-up time, a time of day that they're going to wake up every day of the week for the rest of the treatment period. Third, a bedtime is determined using the wake-up time as an anchor and limiting the amount of time somebody has in bed, or what we call the sleep opportunity, to be equal to the average total sleep time that we saw from the prior week. So we try to make sleep opportunity equal sleep ability. So just to use a concrete example, if somebody is able to generate 6 hours of sleep, and that's what their sleep diary shows us, and they want to wake up at 6 a.m. every morning, then they would get 6 hours sleep opportunity at night. So if they wake up at 6 a.m., they go to bed at midnight, and their new sleep schedule moving forward is midnight to 6 a.m.
All right, so we know that you've only been able to generate about 6 hours of sleep on average per night right now. And it sounds like you can pretty reliably and consistently get up and get out of bed every morning at 5 a.m. So if we're going to go ahead and set that schedule, this means you would need to get into bed to go to sleep each night at about what time?
I guess around 11, because 11 to 5 would be 6 hours total in bed. Is that right? That sounds pretty hard.
That's exactly right, and it might actually be pretty hard. However, if you stick with it, there's a lot of research showing that it really will work. So why don't you go ahead, write that down on here so you'll remember every single night you're going to get in bed, get ready to go to sleep at 11 p.m. And every single morning you're going to wake up and get out of bed right away at 5 a.m. And that's even on your days off.
Yeah, even on my days off? That sounds pretty hard. I'll give it a shot though.
All right.
Okay, and finally, the fourth step is that the sleep schedule is confirmed with the client, and again, it's very important that the clinician makes sure that the client understands the rationale behind sleep restriction therapy and problem solves any potential barriers to adhering to the treatment.
So thinking about this new sleep schedule that we just set for your week, do you think you're going to get more sleep or less sleep than you usually do?
I guess less this week. I mean, my insomnia is not gonna disappear instantly over the next few days.
That's exactly right. So it's not going to be that surprising if you actually get less sleep than usual over the coming week. But believe it or not, that's actually a sign that the treatment is working.
Okay, if you say so. I mean, I think I can get behind that, but I mean, at the same time, I haven't been to bed. I haven't stayed up that late since like high school. I really don't know how I'm going to do that.
Okay, well, why don't we go ahead and talk about that? What are some things that you think you could do to help stay awake?
Wow, so let me get this straight. So you prescribe a sleep schedule that limits your clients' or patients' time in bed to only the amount of time that their sleep diary shows they are able to sleep.
Yeah, that's correct. This is actually a fairly difficult part of the treatment for many clients. And so we think it's really important to understand things like the motivational factors for why somebody wants to make their sleep better and change their sleep schedule. We think it's very important to be clear on the rationale for treatment, for addressing potential barriers to adherence, and for giving lots of encouragement to the client as they begin this process of changing their sleep habits.
Can you tell us now about the second treatment technique called stimulus control? What is this all about?
Sure. So stimulus control involves instructing the client on how to change his or her behaviors so that the bed in the bedroom becomes associated with being sleepy and relaxed rather than having the bed in the bedroom being associated with being awake and alert. In essence, it's designed to both address the perpetuating factors and to reduce the conditioned arousal that they experience. Like sleep restriction therapy, stimulus control involves 4 basic directions. First, only get into bed and try to go to sleep when you are feeling sleepy. And this is true if it's the beginning of the night or the middle of the night.
Okay, I think I'm sleepy enough to go to bed.
Second, if you are not actually feeling sleepy, or if you're lying in bed starting to engage in one of your perpetuating factors, like worrying about what's going to happen tomorrow, then you need to get out of bed. Because again, if you're lying in bed awake, you're pairing I'm in bed, I'm awake. And that's the pairing we're trying to break apart with this.
Oh, I can't sleep. I guess I gotta get out of bed.
So first, only get into bed when you're sleepy. Second, if you aren't falling asleep or you find that you're not sleepy, get out of bed. And then third, once you're out of bed, only go back to bed when you think that you're ready to fall back asleep. And so many people find it helpful to sit in a dimly lit room, doing some relaxing type of behavior that is conducive to becoming sleepy again. And then the fourth rule, and this is a big one, the fourth rule is do nothing in your bed but sleep. Because anything you're doing in your bed that isn't sleep means that you're awake, and you're pairing I'm in bed, I'm awake. And that's what we don't want to do.
Hey Chris, remember you're not supposed to do anything in bed except sleep.
I see. So stimulus control is basically helping the client shape his or her behaviors so that he or she is only in the bedroom when feeling a state of sleepiness and never in the bedroom when feeling a state of alertness.
Yeah, that's the basic idea.
Dr. Drummond, thank you so much. I just have one last thing. Where can someone learn more about CBT-I?
Great question. On the screen is a list of resources that folks can use to try to learn more about CBT for insomnia and the treatment strategies that we talked about today and the other components that are often part of the treatment that we didn't talk about today.
Great. Thank you so much.
You're welcome. My pleasure.